have a persistent left supravenous cava, as you see in this case also, the brachiocephalic vein is absent because the brachiocephalic vein typically connects the LSVC to the supravenous cava. Now, in this particular case, there are other abnormalities. As you see, the aorta is very small. Here you have a supravenous cava and a persistent left supravenous cava, and you have an azygos and a hemiazygos plane draining into that. So let me just reach back to my presentation. Apologies for what happened. Okay, so now it is really important to actually make sure that that additional vessel that exists is not actually the vertical vein in a case of supracardiac total anomalous pulmonary venous return. So as you see in this situation, when you have a supracardiac total anomalous pulmonary venous return, you see that the four pulmonary veins drain into a confluent vein, and then there's a vertical vein that takes the blood to the brachiocephalic vein to come down through the supravenous cava. And what you see on color Doppler, you see a fourth vessel at the three-vessel trachea view, but the direction of blood flow is in opposite direction to the supravenous cava, and that's an important anatomic feature to help you differentiate that. So going back to a persistent left supravenous cava typically drains into the coronary sinus, so you will have an enlarged coronary sinus, and you have an absent brachiocephalic vein, as we've discussed before. Whereas in total anomalous pulmonary venous return, the coronary sinus will be normal, but the brachiocephalic vein will be dilated because now you have all the pulmonary venous blood flow going to the brachiocephalic vein, resulting in its dilation and size. And color Doppler will show a different direction of blood flow between that vertical vein and the supravenous cava. Now, there are ductal arteriosus aneurysms or kinking that you could see, as you see right here. These are typically normal if there are no other associated abnormalities as the ductus arteriosus closes after birth. A couple of words on the aberrant right subclavian artery, clearly seen in the three-vessel trachea view. You have to reduce your velocity scale and increase your gain. You see that aberrant right subclavian artery running behind the trachea from the left side into the right extremity, as you see right here. There is an association with trisomy 21. When you see this, if isolated, typically the association is not that significant, but in the presence of other findings, certainly there should be some counseling and discussion for chromosomal analysis. So the three-vessel trachea view and the anatomy of the LVOT are really, really critical in the evaluation of the great arteries. As you can see, there's a long list of cardiac malformations that are associated with abnormalities in the three-vessel trachea view and also in the LVOT, as I've discussed, as I've showed you the anatomy before. And making sure that you are well aware of the normal anatomy of the three-vessel trachea view is really critical in your evaluation of cardiac malformation. So I think it is one of the most important ultrasound views in the fetus, certainly with the four-chamber view. It is easy to obtain, especially in early gestation, very, very powerful in early gestation to screen for the great arteries. The anatomic landmarks are easy to identify and master, affected in most congenital heart disease, and it should be incorporated in screening ultrasound examinations. I'm happy to say that it is almost there. It is part of the ISWAG basic guidelines, and it is part of the AIUM basic guidelines if technically feasible. Thank you very much for your attention, and I hope that you enjoyed the presentation.
All right, so after this very nice talk of Professor Abu Ahmad, it's now my pleasure to introduce our last speaker. He actually doesn't need a big introduction, although he deserves it. Everyone knows him, his skills and his commitment. He is actually the lead of the Center of Perinatal Diagnostics and human genetics in Berlin. Professor Chowie is the key speaker in many, many, many international meetings, and it's always very impressive to see his refreshing approach on different topics. And I guess today it will not be different. So, Professor Chowie, the floor is yours to present on the fetal venous system.
Good morning, everybody. In this talk today, I will be discussing with you the fetal cardiac venous anomalies, showing you normal and abnormal findings. When we are presenting the typical planes used in fetal echocardiography, either in our book or in the recently published ISWA guidelines, we are mainly focusing on the ventricles and on the arteries leaving the heart, like the LVOT, RVOT, or three-vessel trachea view. But in addition to these planes, there are other planes dedicated to the fetal venous system. You should know, especially if you are performing a target examination. And in this talk today, I will be showing you three typical anomalies. The planes used for the analysis of the fetal venous system will start with the upper abdomen and axial abdominal view, showing you in one plane the demonstration of the umbilical and portal venous system from the left and right portal vein together with the merged together with the main portal vein and the portal sinus, and moving to the little bit higher plane, where in the plane 2 you see the hepatic veins. In the third, in these views, you see that the between the first and the second plane there is the ductus venosus connecting these two. In plane 3, you see clearly the coronary sinus, which is a plane a little bit lower than the plane used for the fourth chamber view. And in the fourth chamber view plane, slightly going toward the LVOT, you may recognize the two pulmonary arteries. The pulmonary arteries are better seen by using color Doppler, either from apical or even better is from a lateral view, where you see the either the two inferior or the two right-sided veins or two left-sided veins entering the fetal left atrium. In the next plane, in the three-vessel trachea view, by magnifying the image and adding more contrast, you'll see the azygous vein entering the superior vena cava. And as you see here in color Doppler, it may be well demonstrated nowadays as a third arc, which is called the azygous arc. And in the upper plane, once you have left the three-vessel trachea view, you see the left brachiocephalic vein connecting the jugular vein to the superior vena cava. Turning the probe into a sagittal view, you recognize the superior vena cava and inferior vena cava ending or merging into the right atrium. So that means these are planes. If you are adding these planes to your examination, I'm sure you will detect this and that anomaly or to confirm the normality of the findings. The three topics I'm going to discuss with you today are the persistent of the left superior vena cava, the interrupted inferior vena cava with azygous dilation, and the total abnormal pulmonary venous connection. Let's start with the first one. In this anomaly, you see this is the normal shape of the upper veins from the jugular vein and the brachiocephalic vein. You see that there is a bridging vein between the left side and the right side, and the persistent superior vena cava. This bridging vein is absent in almost all cases, and the connection of the left-sided veins, neck and arm veins, will go toward the coronary sinus and drain into the right atrium via the dilated coronary sinus. It is a common condition found in 1 out of 300 cases. In many cases, it's an isolated finding as a variant, but it can be associated with other abnormalities. The way to detect this condition is one of 4 axial planes at the level of the fourth chamber view, at the level of a higher plane of the fourth chamber view, and then in the three-vessel trachea view, and then higher plane to demonstrate the absence of the brachiocephalic vein, or turning the probe into a sagittal view to demonstrate the left superior vena cava draining into the left side of the atrium and into the right atrium. So you see here in this plane, we'll have the left superior vena cava as a cystic structure, like at the border of the left atrium. And you see this is the kind of scene. And this is why it's quite tricky to be seen. Occasionally, you may discover that at the level of the fourth chamber view, the left ventricle may be more narrow than the right ventricle. And in a bit lower plane, as I told before, there is the coronary sinus dilated, which is the place where this vein is draining into the right atrium. Now, by using color Doppler, because the vein is draining into the right atrium, you see the blood flow from the left to the right side into the right atrium, as you see here in blue. And this allows you to differentiate it from the presence of an septum primum defect, where the flow is from the right side to the left side of the heart. In other words, it could be seen then in red. Moving to the three-vessel trachea view, you will find a fourth vessel. This vessel is not at the level of the in the anterior part, but more the posterior part, and which is here well seen as an LSVC. So this is why I don't seek it at the same level of the SVC, but more at the level of the ductus arteriosus as a fourth vessel. You see here on the color Doppler, on a video clip, how it looks like. But look at also this interesting case, because it shows you also a narrow aortic arc, which is a hint of a coarctation of the aorta. Now, you know that this condition is highly associated with the presence of aortic coarctation, even if you don't see it antenatally. So consider this condition always when you see an LSVC. Moving to the upper thorax, where you are expecting to see the left brachiocephalic vein, you see an absence of the vein, and you see an empty space behind the three-vessel trachea view. So this is here the thymus, and it should have been shown that there is a bridging vein here, and the LSVC is not present. You see here at 16 weeks case and a 22 weeks case. With color Doppler, we may see, if you have an oblique view, that the two veins, the right and the left side vein, are going into the heart, toward the heart, in other ways, the same direction, while in some cases where you have such a structure, it could be also a vertical vein. In a case of an abnormal lung vein drainage, the vein will go up into the upper thorax. So this is why I'm using this to demonstrate this. And also in early gestation, sometimes when you have the impression that there is something like a left superior vena cava, this vessel can be of help by using color, that you can see the structure, because on without color Doppler, you cannot see it. And this fetus had, by the way, a trisomy 21, so it was also an additional hint, along with an abnormal great vessel, as you see here. So, and you see here, this is again the typical sign of the absence of the left superior vena cava in almost all cases. So there may be some isolated case where they're still present, but in cases I've seen, almost all will have an absent LSVC. Here a summary as a video. You see here the dilated coronary sinus, the kind of cystic structure along the left atrium, the three-vessel view with the fourth vessel, and the absence of the bridging vein here in these cases. Again, you see here the cystic structure, the dilated coronary sinus, and the three-vessel trachea view, a fourth vessel at the level of the ductus arteriosus, and the absence of the bridging vein. Now, turning the probe into a more parasagittal view, because it is on the course on the left side, you see the left superior vena cava draining into, it looks like into the left atrium, but it's under the left atrium toward the right atrium. By adding color Doppler, you see that the flow is going from up to down, that means from the neck toward the heart, which is helpful in differentiating this from vertical veins going up into the thorax in abnormal lung vein drainage of supracardiac type. And you see here on 3D, you can demonstrate also the flow from the neck toward the heart, both on the superior vena cava and on the left superior vena cava. What is the clinical impact of this disease? Keep in mind, it can be isolated if you detect it as an add-on sign, but it can be also as venous anomaly, part of heterotaxy syndrome. Seek for other venous anomalies, seek for complex cardiac malformation, and especially that abdominal organ arrangement. It can be also part of aortic coarctation. This is, for me, the most challenging part. And it can also be part of an abnormal lung vein drainage, since venous anomalies are present in these cases as well. And also in syndromes, not only in trisomy 18 or 13, as reported in some cases, but also in rare diseases. And even you think it's isolated prenatally, you are not sure that postnatally it's not part of a coarctation, and then the coarctation could be a hint for this syndromic condition. In this meta-analysis published many years ago, it was shown that 50% of the cases were associated with cardiac extracardiac anomalies, and 3 of them were detected only postnatally. 12 had chromosomal anomalies, and 7 even in isolated cases. So be aware about this number. So I tell my patients roughly 10% may have a genetic background, and the cases apparently being isolated may develop into coarctation. So when I see this condition, I will always have a control later on gestation, analyzing the ventricular disproportion in the level of the fourth chamber view, and getting as possible in kind of aortic arc dilated visualization to rule out coarctation. But I will write in my report, because of this condition, rule out postnatally a coarctation of the aorta, because it was shown that the association is highly suspicious. Now we move to the next disease called interruption of the inferior vena cava with the azygous continuation. This is typical condition seen in some complex cardiac anomalies like the left isomerism. What we see here is the absence of the inferior vena cava, but not the complete IVC, only the intrahepatic part of the IVC. It means until the level of the renal veins, everything is normal. That means we have 2 iliac veins getting into the level of the to the IVC until the level of the renal veins, and then they turn to connect to the azygous vein, leading to its dilation. And the azygous, as you know, is connected to the superior vena cava, or sometimes it can be also the hemiazygous, which is dilated. What we can get here from these views is to have the different planes where you can demonstrate this condition. You can demonstrate it at the level of the upper abdomen, of the fourth chamber view, of the 3-vessel view, or in the sagittal or parasagittal views. And this is what I'm going to show you in the next slide. So you see here, this is the plane of the level of the abdomen. You have an absence of the IVC and azygos and aorta side by side, which was called the double vessel sign. Here again, demonstration at the level of the upper abdomen, the azygos side by side to the aorta, at the level of the fourth chamber view, the azygos side by side to the aorta, and then in an upper plane here, we'll have a dilated azygos arc where the azygos become visible. Under normal conditions, it's rarely that you see the azygos unless you have a high resolution probe and more little bit late gestational age, but in general you don't see the vessel. And then by putting color, it will show you the flow. This is really important to have color because you can demonstrate this. Otherwise, look into this plane, you may think it is double aortic arc, and this is here a picture how you differentiate between the double aortic arc and a dilated azygos. In the double aortic arc, you will have here the trachea between the 2 branches, and you have a superior vena cava separate on the right side, while in dilated azygos, this part is the dilated superior vena cava, and you have the trachea here. So it is so typical a picture, and you see here this is the superior vena cava can be the hint. Now let's move to the next video case. You see in the upper abdomen, the stomach, and the heart on the left side, but you see here the 2 vessels behind the heart. And look at now again this cardiac problem. We have an AV septal defect, and we have a bradycardia, which is a hint of the presence of a left isomerism. And by accident, you see here also a left superior vena cava. As I told you before, left superior vena cava can be a hint of isomerism. So these typical signs are a good combination at 16 weeks gestation to detect this isomerism case. And here from the same case from the apical view, You see this is aorta, and this is the vessel is on the left side, which is the hemiazygous case, and you see the AV septal defect, typical for the left isomerism case. Now, when you see the double vessel sign, you can turn the probe in order to get sagittal or parasagittal view. There you are able to demonstrate the two vessels side by side. In general, under normal conditions, you will have the inferior vena cava as soon as it's coming into the direction of the diaphragm, it's getting up into the heart, and you see here side by side vessel. By adding color Doppler, you see that the flow will go in the aorta from the thorax into the abdomen, and in the azygous vein, which is then dilated from the abdomen toward the heart. So they have opposite colors, and depends which plane you are getting and how is your oblique view you are presenting. You see here the azygous and the aorta side by side again, and it means the color is not always that the aorta is blue or red, but you see here depending on the angle you are using, but always you have two different colors in the azygous and in the aorta. And by using 3D tool, you see the azygous side by side by aorta as a dilated vessel. You see the star showing the absence of the inferior vena cava, and an axial view in the upper thorax shows you the dilated azygos emptying into the superior vena cava. Again, is a summary, an interruption of the IVC with azygos continuation is typically found in left isomerism, what was called earlier polysplenia, but it can be also an isolated finding, so you are not always obliged to find a complex cardiac malformation. We have seen it in many cases in isolation, but it can be also a hint for additional venous anomalies you have to seek for, or show you later on a case where this can be the first hint to the next abnormality of the venous system. The third group I want to discuss with you is the abnormal pulmonary venous drainage, as here I will discuss today mainly the total anomalous pulmonary venous drainage. You see here, as I told you before, the ideal plane to see the pulmonary veins is the axial, the four-chamber view, where you see the two inferior veins draining into the left atrium. But ideally, if you want to demonstrate 2 or 4 veins, get a kind of right lateral view where you see the 2 right and the 2 left veins, as reminding the crab. It was called the crab sign from the right side, that you can demonstrate all 4. In general, under normal scanning conditions, we say it's enough to visualize 1 or 2, but if you want to demonstrate all 4, this can be the ideal plane. Now, in this paper published some 10 years ago, in 19 cardiac centers, multi-central examination from the UK, Ireland, Sweden, and so on, they reported on 424 cases of abnormal lung vein drainage in the neonate or in the child, and they found out, according to their statistics, that only 8 were diagnosed prenatally, which is a rate of 2%. In other words, this is by far the worst diagnosed condition prenatally, and this is why in almost all centers in the world there are cases which were misprenatally, and these are considered as not associated with isomerism. So you can discover them if there is an isomerism or you have a complex cardiac anomaly, but on its isolation they are really quite difficult to be detected antenatally. So the localization, the classification is there are 3 or 4 groups. 3 groups are supracardiac, cardiac, or infracardiac, and 10% are mixed group between some of these 2. They can classify it also in partial and total abnormal lung vein drainage, and also from clinical point of view in obstructed and versus non-obstructed. The obstructed one are by far more severe, of course. You see here, these are the 3 groups, type 1, type 2, and type 3. Type 1 is called the supracardiac, means that veins are draining into a vein getting to the heart from the superior vena cava, or cardiac at the level of the heart, so the veins drain into the right atrium directly, or infracardiac, draining into one of the liver vessels, mainly the portal veins, and then draining back into the inferior vena cava to the heart. Let us discuss now each one of them in isolation. You see here again on the schemes that you understand what we have to seek for if we are seeking for these anomalies. we see the two pulmonary veins draining into the left atrium and draining here into a confluent vein, and the confluent veins drains into the coronary sinus, drain to the right atrium. Another condition of a cardiac type may be that the confluent vein may directly connect to the right atrium without the presence of the coronary sinus dilation. So these are the two types of the cardiac possibility. The supracardiac, the veins are draining into the confluent vein, and the confluent veins connect to a vertical vein which drains into the left brachiocephalic vein, leading to its dilation, and then a dilation of the superior vena cava as well. And in the infracardiac type, you see the four veins are drained in the confluent vein, and the confluent veins goes through the diaphragm via a vertical vein and drain into the portal venous system and come back into the IVC to the heart. So in other words, the postnatally, the arterialized blood will not reach directly the left atrium as planned, but it will reach the right atrium either via the superior vena cava or inferior vena cava or directly or the coronary sinus. And this is why it's going to be a mixed blood, and the arterialized blood need to be reaching the left ventricle and not the right ventricle. This is why the babies, they have severe problems, and if you give them postnatally prostaglandin, it will not change anything because it's not ductus dependent. So this is why it's crucial to have this diagnosis done prenatally, and let's discuss how we discover it. You have heard from the three types, there is one common sign I was discussing. It was the presence of the confluent vein, which is in the schemes was behind the heart. This is why the way to detect a abnormal lung vein drainage is to focus on the presence of a confluent vein behind the heart. That means on an area which is enlarged behind the heart. Now you see here, there was a paper published by Dr. Kavatsu from Japan. What they said if there is a condition where there is a confluent vein behind the heart, the area behind the heart is going to be enlarged. And they analyzed one detected case and they added to it 7 not detected. And they found out that the area is larger. And to quantify this, they made the relationship of the distance between the heart and the aorta in relationship to the descending aorta diameter. So under normal conditions, you have the aorta and the area or the region between the aorta and the left atrium is quite equal, or even larger aorta than the distance, while in abnormal lung vein drainage, you see the aorta is smaller and the region is larger, leading to a ratio which is enlarged. So if you take the distance divided by the aortic diameter, it will be less than 1, and then it was more than 1. So in other words, if you look at this heart, I hope that in the past you were spending time on trying to get to the final diagnosis to say, is it a single ventricle? What kind of ventricle? Is it a double inlet left or double inlet right, or what is kind of the disease? But if you focus then on the region behind the heart, you see that the area is enlarged, and you're taking the area divided by the descending aorta, is really by far more than 1, and we'll discover that there is an abnormal lung vein drainage. This is why I'm sure many of us have seen here and there a case not detected prenatally, and because of termination in some places in the world, or waiting until birth and the baby dying just after birth or in utero, this condition was not diagnosed, but it was present. This is why I'm sure when you focus on your cases, you may discover this in that case. We see this is more a recent case where the heart appeared normal only because of the presence of this enlarged vessel, confluent vein behind the heart. The diagnosis could have been made. You see here, once you know this sign, you will see it more easily, probably if you focus mainly on the 2D. And you see here on the 2D, there is behind the heart, the area enlarged area, and again, and you see some irregular structures, which are the typical signs of abnormal lung veins in these planes. By adding color Doppler, you have to be careful, because you will see color Doppler there, but you don't see the separate entrance of the vein into the left atrium. They are close to each other. So if you see veins close to each other, be careful not to cover with color Doppler the diagnosis. And this is the typical picture of the confluent vein with the area behind the heart enlarged. Again, here, several cases at different gestational ages show you the typical sign of these veins behind the heart as a hint for abnormal lung vein drainage with color Doppler. Using spectral Doppler of the vein, we know that under normal conditions, you have the triphasic flow, the S, D, and A. And when you have a fetus with the abnormal lung vein drainage, often the shape is changed, especially when there is an obstruction. It's turned to be more continuous. So this is why be careful if you are having this flow. It may be a typical hint for abnormal lung vein drainage, and especially these one with obstruction. In other words, some of the colleagues say when you have either fetal echo in general, when you have some suspicious, or when you have a fetus with a cardiac anomaly, why not to do regularly pulse Doppler of the lung veins in order to discover whether there is a normal flow or whether laminar flow, because you may not be always able to discover an abnormal lung vein drainage if you are not focusing on it. So using the spectral flow of the lung vein may be helpful in detecting cases where you are not very sure by your 2D or color Doppler image. Now let's go step by step the three types. If you see here fetus with a cardiac type, the typical picture I'm looking at is to see the dilated choresinus. So this is a case we published in the White Journal 10 years ago, where you see here that in the fourth chamber view, there is an azygos and the aorta and the dilated choresinus. We thought first, of course, it is a typical case of a left superior vena cava associated with an azygos because there is dilation. So we get back to the upper thorax and we saw the aorta and pulmonary artery, but there was no left superior vena cava. In other words, how can the coronary sinus be dilated if there is no left superior vena cava? And we assume, oh, it could be another reason where there is dilation. For instance, can be the lung veins draining there. And so going back to the fourth chamber view, we saw that there is a confluent vein here behind the heart draining into the coronary sinus. You remember I told you the azygos, the presence of an azygos vein may be a hint for abnormal lung veins. And this is here also in coronary sinus dilation along with the confluent vein in a cardiac type of abnormal lung vein drainage. We move to the next one, which is the supracardiac type. The supracardiac type will here seek for the lung veins behind the heart, and you see that the confluent vein will drain into the vertical vein, which is then draining into the brachiocephalic vein, leading to its dilation. So in other words, getting a sagittal view or parasagittal view, you see the vein